testicular artery, testicular veins, testicular lymph vessels, autonomic nerve, remains of process vaginalis, and genital branch of uh, genitofemoral nerve. And this is detailed in a new tunica vaginalis, which attached posteriorly. Risk factor of uh, testicular torsion is underlying bell clipper deformity, undescended testes, long spermatic cord. It's due to trauma, prior history of testicular torsion. This is bell clipper deformity. In this deformity, the tunica vaginalis completely surrounds the testis, epididymis, and part of spermatic cord, predisposing to torsion. This is uh, tunica vaginalis abnormal position. The congenital abnormalities present is approximately 12% of males and bilateral in 40% of the cases. Pathophysiology, torsion occurs as the testis rotate between 90 to 180 degree, compromising blood flow to and from the testis. Complete torsion usually occurs when the testis twist 360 or more. Incomplete or partial torsion occurs with lesser degree of rotation. The degree of rotation may extend to 720 degrees. The twisting of testis causes venous occlusion and engorgement as well as arterial ischemia and infarction of the testis. The degree of the torsion of the testis indoors may play a role in viability of the testis over time. In addition, time is most important factor. 6 to 8 hours is very favorable time. There are two types of testicular torsion, intravaginal and extravaginal. Intravaginal is the most common type, occurring most frequently in puberty. It results from anomalous suspension of testis by long stalk of spermatic cord, resulting in complete investment of the testis and epididymis by tunica vaginalis. The anomaly has been linked to the bell clipper deformity. Extravaginal most often occurs in newborns without the bell clipper deformity. It is thought to result from a poor or absent attachment of the testis to the scrotal wall, allowing rotation of testis, epididymis and tunica vaginalis as a unit, and causing torsion of a cord at the level of external. These two pictures showing intravaginal torsion, the tunica vaginalis, the cord present in the tunica vaginalis, and the cord rotates outside the tunica vaginalis. An abnormal mesentery between the testis and its blood supply can predispose it to the torsion if the testis is broader than the mesentery. The contraction of the spermatic muscle shortens the spermatic cord and may initiate testicular torsion. Mechanism of testicular infarction, testis rotate on spermatic cord and they cause the venous occlusion and edema, which cause the arterial ischemia and which lead to infarction. The patient present with the history of severe unilateral scrotal pain. Previous episodes may have history of previous episodes and spontaneous resolution related to activity, trauma, or during deep sleep. The initial presentation is nausea, vomiting, abdominal pain, and fever. Now the physical examination of the patient in units, the testis is firm, hard, maybe feel like scrotal mass, which does not transluminate in otherwise asymptomatic newborn male. The scrotal skin characteristically fixed to the necrotic gonad. In older patient, a swollen, tender, high riding testis with abnormal transverse lie uh, and loss of cremasteric reflex. Uh, Cremasteric reflex almost always absent or diminished, and its presence may be other cause of uh, acute scrotal pain. And friend sign, relief of pain with the elevation of testis, which are mostly unreliable for the diagnosis.
Yeah, what we call this thing, the absent in restrictive reflex. This is again a sign.
Basically, this sign can be elicited by stroking the finger along the side of the thigh. And as a result of it, there will be the upward elevation of the testis. So this sign will be absent in case of this.
It never is not.
Genitofemoral, genitofemoral.
जैसे कि जेनेटिक फिमरल के दो इसके कंपोनेंट्स हैं। जेनेटिक फिमरल फिमरल जो है वो यूटिलिटी सप्लाई करती है मिडिल साइड अपर मिडिल साइड ऑफ थाई। और उसको स्ट्रोक करेंगे तो जो जेनेटल जो उसका जो ब्रांच है उसके थ्रू ये डिमेस्टिक कॉन्ट्रैक्शन होती है। L1 L2 उसकी रूट वैल्यू है, L1 L2 रूट वैल्यू है। साइन को क्या कहते हैं? द टू कॉमन साइंस इन टेस्टिकुलर टॉर्जन, ये हमें रटे होते रहते हैं।
Clinical diagnosis based on examination and history. There are scoring system, testicular workup for ischemia and suspected torsion, scoring system, a clinical decision tool determining the risk, thus decreasing the indication of ultrasound. You are working in for area in which ultrasound are not available, then you can use the scoring system. The first hard test is they have two number. Absent cremasteric reflex, they have one number. Nausea and vomiting one. High riding testis is one, and testicular swelling is two. A score of 0, 100% negative predictive value, and a score of 6 to 7 is highly predictive of torsion. Twist scoring interpretation. If score is between the 0 and 2, there are very low risk of torsion, 100% negative prediction value of a torsion, and generally no ultrasound in urological consultation needed. Between the score 3 and 4, there are intermediate risks and ultrasound needed. And score 5 or above, there are high risk, 100% positive predictive value for torsion, and ultrasound not required, urgent urological consultation and surgery required for salvage. And diagnosis of torsion is with the nuclear sensitography, but they have radiation and limited availability. And ultrasound, there are two modes of ultrasound, color Doppler and which show the vascular and B mode, and infrared scrotal spectroscopy. Ultrasound for testicular torsion, their sensitivity is 86% and they are 100% specific. Experience provider using color or power Doppler. Grayscale finding on ultrasound depends how much time has passed since the torsion occurred. The grayscale findings of acute and subacute torsion are not specific and may be seen in testicular infarction caused by epididymitis, epididymoarthritis, or traumatic testicular rupture or infection. Early stages, scrotal content may have a normal sonographic appearance. After 4 to 6 hours, testis become swollen and hypoechoic, and after 24 hours, testis become heterogeneous as a result of hemorrhage, infarction, necrosis, and vascular congestion. The epididymal head appears enlarged and may have decreased echogenicity and may become heterogeneous. The spermatic cord immediately cranial to testis and epididymis is twisted, causing a characteristic torsion knot or whirlpool pattern of concentric layers. This is a whirlpool sign. This also shows the whirlpool sign. Colored power Doppler sonography, most useful and most rapid technique of diagnosis and differentiation. Blood flow is absent in the affected testis and significantly less than in the normal contralateral testis. In early torsion, no flow observed, and the echogenicity is the homogeneous testis. And in the late torsion, heterogeneous exotexture and increased extra testicular blood flow. Meticulous scanning of a testicular parenchyma with use of low flow detection Doppler setting, low pulse repetition frequency, and low wall filter, high Doppler gain is important because testicular vessels are small and have low fall flow velocities, especially in the prepubertal boy. There are differential diagnosis of testicular torsion, uh, appendage torsion, uh, and spermatic cord torsion. May have epididymitis and scrotal wall edema or erythema due to some insect bite and skin lesion, orchitis, and trauma, hernia or hydrocele, inguinal hernia without incursion, communicating hydrocele, insisted hydrocele with or without torsion, and maybe in adult they present with the varicocele, intrascrotal mass, cystic dysplasia, or tumor of the testis, epididymal cyst, and they may have musculoskeletal pain, and the pain may have referred pain due to ureteric stone, distal ureteric stone. Torsion of the testicular appendages, mostly they use blue dot sign, blue dot seen on the side of the testis, and they lack blood flow in appendage testis, and also have on color Doppler loss of blood supply to the appendage. Nuclear imaging, technetium per technetium is the agent of choice. Immediate radionucleotide angiograms are obtained with subsequent static images as well. In healthy patient, images show symmetrical flow to the testis, and delayed images show uniformly symmetric activity. In the subacute and late phase of a torsion, mistorsion, there is often increased flow to the affected hemiscrotum via pudendal artery or photopenic testis, and a rim of surroundings increase activity on a static images. This has been called a rim donut or bullseye sign. Near-infrared spectroscopy. Near-infrared spectroscopy is an emergent tool to assess testicular torsion. It can measure oxygen saturation 3 to 4 centimeter deep in the skin, is rapid, lasting for 20 seconds, and it is non-invasive. The treatment of testicular torsion, immediate surgical exploration is indicated for a patient with the testicular torsion. For reliable salvage of the testis, surgical repair must occur within 6 hours of symptoms onset. If the treatment is delayed, the patient may experience decreased fertility or may require orchidectomy. Surgical detorsion is a definitive treatment for testicular torsion. Manual detorsion of the testis may be attempted, but it is usually difficult because of acute pain during manipulation. Non-operative detorsion is not a substitute for surgical exploration, but it may improve the rates of surgical salvage and can protect testicular viability in the cases of surgical delay and also provide significant pain relief. In manual detorsion, like opening a book is successful and confirmed by color Doppler sonogram. In a patient with complete resolution of symptoms, the patient should undergo definitive surgical fixation of the testis before leaving the hospital so that the operation can be performed as an urgent rather than emergent procedure. This is opening a book manual detorsion. From medial to lateral, the patient rotate his legs and arm, and they cause the detorsion of the testis. Surgical detorsion, treatment of testicular torsion varies according to the patient age. Neonatal torsion is controversial, but is most often treated with the elective exploration and contralateral orchidopexy. Because bilateral synchronous or asynchronous neonatal testis torsion has been described. In older patient, transfer the patient to the operating room for urgent scrotal exploration, regardless of the number of hours since the onset of presenting symptoms. Intraoperative details, either a midline raphe incision or bilateral transverse scrotal incision can be made. If the testis is necrotic, perform an orchidectomy to prevent subsequent torsion. Fix viable gonads to the scrotal wall with 3 to 4 non-absorbable sutures.
We've got two cases here. The first case is a 15-year-old boy wakes up from sleep with a sudden onset of severe pain and mild swelling, and redness on his left scrotum. He vomits for 2 times and is restless. The pain is increased on touching the scrotum. His parents takes him to near the hospital. So, what is the most likely diagnosis in this case? With acute onset, don't have that word this week. Or क्या suggest that it works for them. Either patient wakes up from sleep. उसको prior कुछ symptom नहीं होते, sudden onset होता है. Most commonly presentation में हिस्ट्री ये होती है कि patient बस नींद से उठा है और रो रहा है, बच्चा है, बड़ा है. Severe pain, शोर भी है, transverse lie है, vomiting है. Mostly this patient has got underlying. Second scenario is a 23-year-old male. His gradual has gradual swelling on his right testis with moderate pain over 2 days and give history of dysuria and fever. 1 day back, the pain increases when standing, however, sometimes decreases on the elevating the right testis. So, what is the diagnosis here? Why? Positive trends and good. What else? There's 2 days of history. Patient has dysuria as well, and he's a young male, and positive trends and saying. First case was torsion, and second is epidural arthritis.
This is short video of testicular torsion.
देखो,
The summary of evidence of diagnosis of testicular torsion is based on presentation and physical examination. This is true evidence. Doppler ultrasound is effective imaging tool to evaluate acute scrotum and comparable to sensitography and dynamic contrast enhanced subtraction MRI. This is true evidence. And neonates with the acute scrotum should be treated as a surgical emergency. Their recommendations base the clinical decision on physical examination. The use of Doppler ultrasound to evaluate acute scrotum is useful, but this should shouldn't delay the intervention. Strong recommendation. And manage torsion of appendix testis conservatively. Perform surgical exploration in equivocal cases and in patient with the persistent pain. This is strong recommendation. And perform urgent surgical exploration in all cases of a testicular torsion within 24 hours of a symptoms onset. In prenatal torsion, the timing of a surgery is usually dictated by clinical finding.
Thank you, Abdul Karim. Any question? Sir, any comments, any suggestions? Question? Thank you very much.